I have the privilege of having a half an hour of your time. I'm going to try to cram a lot of information into this half hour, and I will probably talk way too fast. You will probably forget most of what I'm going to tell you. Nice thing is I have an opportunity for those of you who are going to do your residency here. I will get in front of you hopefully several times during the course of your residency, and we can expand on some of the things that I'm going to introduce tonight. So let me start out by saying welcome. Congratulations. I think y'all are going to enjoy your careers. You thought you were going to get to practice medicine, but you're going to get to do so much more than that. And so let's talk about the world of risk management. First thing is, you have patients. They're not profit centers. Doctors, if you go out and poll, I don't care what state you're in, you go out and poll the general public, doctors are all filthy rich. So a show of you filthy rich people out there. You don't need the money. You're rich. Treat them like people. Don't treat them like profit centers or insurance policies or whatever else you want to call them. They're people. Treat them as such. Step number one. Meet and greet your patients by name. Just, hi, Mrs. Jones. Hi, Mr. Jones. How are you? It's good to see you. If it's your first time meeting them, I'm Dr. Smith. I'm going to be working with you today. Be courteous. Doesn't take any time, no time. But I promise you, if you don't do this, that patient will leave there and I will get a phone call saying, that doctor was so rude. And you have set the stage, if there is any mishap, that they're already not going to like you. If they don't like you, and a bad thing happens, there are a lot of attorneys out there who advertise they'll be happy to sue you and see what they can get. So please, just common courtesy. The other thing I want you all to do, and you will do it, but it's an interesting dilemma. I want you to review the medical record before you go in and see the patient. I'm a patient here, and I just get frustrated when I go in and I sign in at the front desk. I go back into the exam room after waiting in the waiting room 2 to 3 hours. Your patients are already frustrated. You go back there and some nurse says, why are you here? So I explain it. I'm here because I'm crazy in the head and I need help. And the nurse writes that down and types it into the medical record. And the next thing I know, a doctor comes in and says, why are you here? It does not fill me with confidence. Now, I understand y'all have got to take your H&P. I understand that. But I would much rather have my doctor come in and say, I understand you're crazy in the head. Tell me more. How can I help you today? But at least let them know you thought enough about them as a person to be somewhat familiar with them before you walk into the room. Again, if you live in my world, you start getting phone calls that the doctor didn't even know why I was there. Had no idea why I was there to be seen, and comes in out of the blind and tries to help me. No, give them some indication you've at least reviewed something. The other thing I'm going to tell you, and I'll tell you over and over and over again, is document in the medical record. Now, my premise is, if it's not in the medical record, you didn't do it. If you look at a test result, document it. If you talk to the patient about something, document it. If you examine some part of the patient, document it. Because I guarantee you, patients are going to look at you or call me and say, they never even examined me. And then they sent me a bill for $139. I'm going to go pull that medical record. I would like to see some documentation there. And I will beat you all up throughout your residency with document, 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 document. It will save your butts. I promise. Some of these things I'm going to fly through. We don't have to write so much anymore. If you do, at least write legibly. If you can't write legibly, Put down a pager number or a phone number so the nurse trying to pull that order can call you and say, I can't read this, what is it? If you're going to do a procedure on a patient, don't do it without that attending being present. Now, I know our facility. I understand our facility. How many of y'all have been around here for the last few years and know it as well as I do? Come on. Y'all know what goes on? No resident would ever start a surgery without their attending present, would they? Uh-huh. We understand each other. I'm telling you, don't do it. Okay? If there's a problem, if there's a bad outcome, most of our faculty are very, very good. They will say, I'll back you up. I'll support you. You made a decision, I'll support you. There are faculty around here and in every other state that's going to say, not my problem. That resident didn't talk to me. That resident didn't tell me what was going on. Not my problem. You will be out there alone. That is not where you want to be. So if there's a problem in a department, in an area, give me a call. But I encourage you to make sure your staff knows what's going on. Informed consent, if there is anything I can pound into you is, you do not do anything to a patient without their informed consent. Y'all have all learned to examine patients, correct? How many of y'all obtain consent from a patient before you even examine them? Anybody get consent for an examination? Why not? What gives you the right to touch a patient without their permission? Anybody? Okay, let me make a suggestion. I'm being a little harsh. The patient makes the appointment. The patient shows up for the appointment. The patient gives it to the exam room, gets up on the exam table. They have implied their consent for you to do this. If you develop good habits early, they will serve you well throughout your career. So again, my risk management advice to you is introduce yourself, say hi to the patient. Hi, Ms. Jones, I see you're here because your knee hurts. I need to take a look at your knee. Is that okay? Make it a habit. What's the patient going to say? No, you can't look at my knee? Of course they're going to say it's fine, but you now have their express permission, their express consent. Get their buy-in, and if you will do that for every aspect of your patient care, I promise you it will serve you well. Nurses are an interesting part of y'all's world. There are nurses who have been doing what they have been doing for a long time. They have a lot of information. And I promise you, if a nurse calls and says, this patient is having a problem, I need you, they probably know what they're talking about. Nurses can be your best friends or your worst enemies. My advice to you is stay on the good side of the nurses. Just suck it up and do it. You don't have to acquiesce to everything because they're not always right, but I suggest you don't blow them off either. Document effectively. I see notes in charts all the time, and I just have to scratch my head and go, what? What? But it's okay. You know what you meant. I think the speaker after me is a brilliant young attorney who is going to help y'all explain some of the notes that y'all write in charts. As you start out, if you will take the time to go back and read a few entries prior to the one you're about to make sure your thought processes flow, okay? Avoid personal comments in the medical record. We had a resident write one of the absolute best histories and physicals I've ever seen written in a chart. It was this was when we were writing them, handwriting them. 2 full pages in the medical record. 2 full pages in their H&P. At the end of that note, they signed it. But above their signature was a word. Now, this patient had a problem, had a complication, so I was reviewing the chart. I came across this H&P, and it was so well done, it was magnificent. And I come to that word, and I look at that word, and I said, I don't remember doing a rectal exam on this patient. Why would we use this word? And I tried to make it read asystole. I really did. But it would not read that way. Apparently, when I talked to the resident, he said, this guy was such a, that I just couldn't help myself. It would not take a plaintiff attorney much to blow it up this big and show the jury you did not respect this person as a person, and therefore you did not give them good care. You keep your personal comments out of the record. Anybody unclear on that? Thank you very much. Second thing is, avoid personal conflicts in the medical record. Y'all will interact with other physicians, other specialists. One of the most egregious stories I can tell you has to do with a patient who is going to have surgery. One of the doctors who's going to be involved in this procedure wanted the patient to have a cardiac workup and actually said, I know you're here for your surgery, but we're not going to do it today. We'll schedule it for 2 weeks from now so you can go have a cardiology workup. The doctor actually scheduled the appointment with the cardiology clinic. Patient shows up 2 weeks later, same doctor, says, looking for your cardiac workup, I don't see it. Patient says, I didn't go. I'm healthy. I don't have any problems. I didn't go, but I want my surgery. Doctor says, nope. Patient says, I demand to have my surgery. There's no reason for me not to go under the knife. I'm healthy. The doctor in question refused to participate. So another doctor comes in, second doctor, and participates. Get the patient on the operating room table, put him under general anesthetic. The patient is there for a fairly simple procedure, arrest and dies on the table. Doctor number one, who was not involved in the surgery at this point, wrote a full-page note on how stupid the other two doctors were to take this patient to the OR. They had no business in that patient's record, none. If you have a problem with the colleague, let's take care of it outside the patient chart, please. If you don't know how to do that, call me, I'll help you. Pay attention. There is no such thing as a hallway consult. If you are asked to look at a patient, if you evaluate a patient, you make a note. You will be asked by another first-year resident, hey, as long as you're here, come on in. I think so-and-so, if you'll take a look and just kind of confirm that I'm right. And so you, because you want to be good people, go in, look at the patient. Yeah, I think you're right. You don't write a note, you leave. That resident is going to say, consulted with. And so your name's going to be in that patient's chart. Now, if they misstate you, misquote you, misinterpret you, you're going to be in trouble. So I'm telling you now, if you see a patient, if you examine a patient, you write a note on that patient. And if whoever it is that's asking you to do this says, no, don't write a note, then you say, then I can't see the patient. Mr. Kutait said, if I see a patient, I write a note. Otherwise, can't help you. I'm telling you, it's for your own good. Now, or when you get into private practice, there are general education questions. I've got a 50-year-old woman with this condition, and I'm thinking about giving her this medicine. Does that sound reasonable? Yeah, it sounds reasonable to me. Okay, fine. But you haven't seen the woman, you haven't examined the woman, you haven't reviewed tests on the woman. It's a general question. But if you see patient-specific information or see the patient, you write a note. Okay, I pounded you off. I pounded you pretty hard with that. My last point that I'm going to do on this presentation is, I told you earlier, Don't tick off a nurse. They'll crucify you in the record. Now, all through medical school, how many times did y'all review nurses' notes? Anybody? Did anybody ever take a look at nurses' notes? Good. Here's my other suggestion. When you're going to go in and see a patient, especially a patient who is admitted to the hospital, my advice to you is take 20 seconds, 30 seconds. Look at the nurse's notes on that patient. The nurses are with that patient 8 to 12 hours a day. They will document things during that course of time that may be important for your evaluation and your information. If you don't look at it, you may never know it's there. That's the reason you review them. Personally, I'd make sure the nurse didn't document something like paged resident 3 times, resident doesn't respond. This resident never responds. If you see notes like that in the nurse's notes, no, do not go and hit the nurse. Pick up the phone, give me a call, say you need to look at such and such record, you're not going to believe what's written there. And I'll help you. Okay? But if you make a nurse mad, I promise you they'll get even. Okay? I want to tell you another story. This is one of my favorite stories. It's one of my favorite stories because in this particular case, we did not get sued. And it amazes me that the resident did not get sued. But what we had a case where we had a 12-year-old girl admitted to the hospital for shortness of breath. Spent 3 days in the ICU. Seemed to be improving, doing much better. Transferred out of the ICU down to the floor. Had been out on the floor for 9.5 hours. Mama, who has been with this child constantly, goes to the nurse's station and says, something is wrong with my daughter. Need to get the doctor here. So the nurse pages the resident. Resident responds promptly, does very good. Goes in, examines the patient, seems to be doing well, writes their note, leaves. About an hour later, Mama's back at the nurse's station. Something's wrong with my daughter. Somebody needs to look at her. Resident gets paged again. Goes back in and examines the patient. Everything seems to be fine. Leaves. Long story short, this happens 4 times over a course of about 2 hours. The 4th time, the resident goes up to the room, does not go into the room, leans up against the door, and looks at Mama and goes. So Mama goes out to the hallway, where the resident proceeds to chastise Mama. The only thing wrong with your daughter is you. You are stressed, you are anxious, you are upset. Your daughter reads that into you. It makes her stressed, anxious, upset, which makes you think there's something wrong with her. Now you go back in the room, we're taking care of her, we'll do our job, and we'll be back when we need to be back. Mama goes in the room, sits down, 45 minutes later they call a code on the kid and lose her. She dies. You think Mama didn't want to hang that resident up? Absolutely. I cannot believe that woman did not sue. Now, all in all, I don't think she'd have won her lawsuit. But she was angry enough that I'm surprised she didn't. If that had been my child, I don't know if I could have controlled myself. But the point is, it took that resident longer to chew Mama out than it did to go in and examine the child. So y'all can get a complex if you want to. We're the doctor, you don't know jack. But I'm telling you, if you're dealing with kids especially, and the parents come out and say something's not right, you better pay attention. Now, what I'm not going to get into in the time I have are the patients who are such problems that you don't want to deal with them, but I will tell you one more story. We had a woman, I'll never forget her, admitted to this hospital. And I got called in because she had been here for 3 days and she was nasty foul, nasty. She had been admitted for an infection in the knee. And I got called in because she would just cuss the residents, she would cuss the nurses, she would cuss the staff. She would take her food tray and throw it across the room and then call administration because her room had not been cleaned. She would spit at people when they came in to treat her. This is how nasty this woman was. Foul. It started going through the chart and everything was very appropriate. Trying to address her infection, blah, blah, blah. Couldn't get her cleared up. She had been on IV antibiotics for days. Couldn't get her cleared up. Finally cultured her wound. It came back with sputum and feces. So she was self-contaminating so that she could stay in the hospital. You get my picture? Nasty, foul woman. So by the time I get called in, frustration levels of the doctors are about this high. And I'm going through the chart, and I come to this one page, and I look at the note, and this is the faculty's note. This is not the house staff. This is faculty. And the note read, I don't want to be her doctor any more than you do. Faculty. And I'm like, what? Can we say plaintiff attorney will have fun with this? And so I called the faculty member, and I know this guy. And I said, you know, you're one of the nicest guys I know. What is this note? And he, just as serious as he could be, he said, Kemal, you're not reading it right. I read it again. I don't want to be this patient's doctor any more than you do. He says, yeah, that's what it says. But what I mean is, what I told the residents and wrote was, I don't want to be this patient's doctor any more than y'all do, but the fact is, she's our patient, and we have to provide her with good quality care. So get in there and go do your job. But that's not what he wrote. It's one of those faux pas. So pay attention to what you're writing. Say what you mean in the medical record, and it'll serve you well. One last thing. Almost all the faculty here know how to reach me. I'm available to you 24 hours a day, 7 days a week. Most of them have my cell phone number. I've got a pager. You can call my office and get my pager if I'm not in. If you have a problem, if you have a question, you don't know how to document something, you don't know how to correct something you've already documented, you have a problem patient, please pick up the phone and give me a call. I will help you. In the event things go south, in the event there's a bad outcome and somebody serves you with soup papers, you're going to call me. You're going to call me right away. Okay? Now, I'm not going to cross this line because you have an attorney that's going to tell you about this. My point being, do not hesitate to call me if you even feel like you need me. Okay?